Hi everyone, today we're talking about opioids. Now, what exactly are opioids? They relieve pain, they provide analgesia by acting on opioid receptors in the brain and spinal cord. They also cause euphoria and sedation, but can slow breathing and lead to dependence. They can lead to addiction in simple terms. Now, opioids are basically drugs. They can be either synthetically made in the labs, or they could be naturally found in the world, in the environment. They're also made in the, or you could also give them from the outside, right? Other than that, you also have receptors. Obviously, these opioids are going to bind to certain receptors, which are specialized proteins, which are found in brain, spinal cord, and even the gastrointestinal tract, and they respond to the natural and synthetic opioids. They play a central role in pain control, mood, and reward. Now, very important, three receptors are mu, kappa, and delta. Now, very easy to remember kappa, depression. So, kappa is basically calm but sad. So, kappa is calm but sad. This person is very calm, so analgesia is there, there's pain relief, but there's also this depression. The person is sad, so there's dysphoria. You may be wondering what's dysphoria. It's the opposite of euphoria. When a person is under euphoria, is high, is very happy. In dysphoria, a person is very low and depressed and sad. All of that, right? So kappa is for analgesia and dysphoria. What about mu? Very important receptor, analgesia. All of these are for analgesia, right? Because opioid receptors. So mu is for analgesia, but it's for euphoria. Kappa is for analgesia and dysphoria. So that's the one difference that you should know, mu and kappa, right? So mu, euphoria and analgesia. Kappa, dysphoria and analgesia. Other than that, mu has respiratory depression, very important. There is constipation, and there could be meiosis. Meiosis is basically pinpoint pupils. Pupils basically constrict. What about delta receptors? Analgesia and tolerance dependence. Tolerance development. That person doesn't get tolerance development basically, right? Now, opioids. When you talk about the classification of opioids themselves, we'll talk about them as well. Before that, let's just look at opioid receptors. So you can see the opioid receptors. Mu's primary effect was, remember, I told you about mu. Whenever a person eats, he's happy. Remember, mu. He eats through mu. So there will be euphoria and obviously analgesia. So analgesia, euphoria, you can just say sedation if you want to. What are the other effects? Respiratory depression, constipation, and also meiosis, I told you. And this is activated by drugs like morphine, fentanyl, and heroin. Heroin is a full-fledged drug. Fentanyl, it's synthetically made. Morphine, it's natural. Clinical importance. Most medically used opioids target this receptor. Then you have kappa. So its primary effect is moderate pain relief, especially in the spinal cord. Other effects, dysphoria and hallucination. So there is moderate pain relief, less addictive compared to mu receptors. Then you have delta receptors. The primary effect is again analgesia, but also mood regulation, or you could say tolerance dependence. These play a major role in antidepressant-like effects. They're less well understood than mu and kappa receptors. Now, opioid receptors belong to a family called G protein coupled receptors. So, what's the family of opioid receptors? Very important. What's the mechanism of action? So, for that, you need to know G protein coupled receptors. So G protein coupled receptors, GPCRs. They reduce pain signal transmission in the nervous system. They inhibit neurotransmitter release. So what do? They decrease the pain signal transmission. They also inhibit the neurotransmitter release. Basically, they inhibit the release of acetylcholine, norepinephrine, substance P, and even in some cases glutamate. That's uh, that's the way it basically stops the pain sensation. So it inhibits neurotransmitter release. And what are the neurotransmitters? These cause pain, right? So glutamate causes pain, substance P, norepinephrine, acetylcholine, all of these cause pain. So if these are inhibited, what will happen? A person will undergo analgesia, will not experience pain. The pain will either be reduced or it will be completely finished, right? Even though the person is still very much conscious. So how can you differentiate between analgesia and anesthesia? Anesthesia is basically it knocks a person out temporarily, of course. It basically makes a person unconscious, and then there's pain relief. But in analgesia, the person is very much awake and conscious in his or her senses, but the pain is not there. It's reduced significantly or completely not there. Analgesia. So, what are the neurotransmitters that cause pain? Acetylcholine, norepinephrine, substance P, and glutamate. So, what does opioids do? They basically bind to the mu, kappa, and delta receptors in CNS and periphery, and it inhibits the neurotransmitter release by closing the potassium channels. Potassium channels basically increases the potassium influx, and then the potassium binds with the vesicles, and the vesicles they fuse with the cell membrane, the synaptic membrane, presynaptic membrane, and then the transmitters are released into the neurotransmitters are released into the synaptic cleft. So if these neurotransmitters are not released, there'll be no pain sensation. And it opens potassium channels, causes hyperpolarization because when sodium channels open, sodium comes in. When potassium channels open, potassium goes out. Because of which, what will happen? There'll be basically repolarization, right? But if it's open for a longer period of time, there'll be hyperpolarization. Okay, then this is basically decreased pain transmission. Because of hyperpolarization, the pain transmission will decrease. What is the mechanism of action? GPCR, and it binds to receptors, inhibits neurotransmitter release, and it opens potassium channels, because of which there will be hyperpolarization and there will be decreased pain transmission. The nerve impulses won't travel further. What are the pharmacological actions? Analgesia, of course, severe and moderate pain, and then sedation and euphoria, respiratory depression, constipation, meiosis, and also smooth muscle contraction, you could say. Antitussive is basically it's used to treat cough. What does antitussive means? It's used to treat cough. There are a few words that you might find difficult, so let's even go through them. What are those words? Let's see. Right here. So dysphoria is a state of unease, discomfort, or dissatisfaction, opposite of euphoria. And it's often caused by the kappa receptor activation. Patient may feel restless, anxious, or unhappy. Antitussive, a substance that suppresses cough. So treats or suppresses. A better word is suppresses cough. So yes, codeine is commonly used in cough syrup. So where was codeine? First, the strong one, right? Morphine. Sorry, codeine was moderate one. Codeine, right? So it's used in cough syrup. So moderate used in cough syrups, right? So that's how it basically gives analgesia to a patient. Works by acting on cuff center in the brain. Analgesia, relief from pain without loss of consciousness. So I hope these are clear. So antitussive is a substance that suppresses cough. It's basically anti-cough syrup or tablet or whatsoever. Now these are the pharmacological effects. Other than that, what are the clinical uses? Obviously, pain relief, then cough suppression also, because I told you codeine it acts as a cough syrup. Antidiarrheal also. Why antidiarrheal? Because why antidiarrheal? Because over here somewhere we studied constipation. So if there's excessive use of these, it could lead to constipation. So basically antidiarrheal. So antidiarrheal is basically constipation, like a person is moving towards constipation, right? So this does what? This can act as an antidiarrheal as well. So also pulmonary edema, it's used in pulmonary edema, surgical anesthesia, and it's used to treat opioid dependence, especially which ones? Opioid antagonists. And you may be wondering what are opioid antagonists. So let's go a little bit backwards, a little bit back. So do not forget methadone and buprenorphine. Let's see. So these are antagonists. You have naloxone and naltrexone. Whereas so here you can see nalbuphine and buprenorphine, mixed agonists and antagonists. Now what are these? So I told you about opioid receptors. Opioid receptors are proteins, right? But there's something that should bind with these receptors. So you have opioids, you have agonists, you have agonists and antagonists mixed, you have antagonists. Very important antagonists, remember naloxone and naltrexone. Then you have agonists, strong, moderate, and weak. Moderate, I've already told you, codeine and oxycodone, which are used in cough syrup, especially codeine. Strong would be morphine and fentanyl. Fentanyl is synthetic, it's made in lab. Morphine is one. Methadone and meperidine. Then you have weak, propoxyphene. So just repeat, morphine and then fentanyl and MM. Then you have codeine and oxycodone. Then you have propoxyphene. What about mixed agonists and antagonists? Do not forget nalbuphine and buprenorphine. Then antagonists you have naloxone and naltrexone. Do not forget these. So mu, kappa, delta, these all we've done. Pharmacological effects also, mechanism of action also we've done. Clinical uses is released as an antidiarrheal, cough suppressant, especially codeine. It's really used as a pain relief, and then pulmonary edema, surgical anesthesia, opioid dependence. Adverse effects: if a person takes them excessively, there would be increased respiratory depression, and this is a very common cause of a lot of deaths in people who take a lot of opioids. Opioids are also commonly it's a very commonly misused drug, right? So if there is excessive use of opioids like heroin or any other drug, so it can lead to respiratory depression. This is a leading cause of death. This results in fatal overdose. So respiratory depression. Other than that, nausea, vomiting, constipation, obviously, sedation and stupor, dependence, tolerance, withdrawal. Overdose triad is coma, pinpoint pupils, and respiratory depression. So a lot of the times, patients come in the ER and they're in coma, they have pinpoint pupils, meiosis, and they have respiratory depression. So it's very easy to tell. Okay, this person has respiratory depression. This you could tell physically as well as by ABGs. Pinpoint pupils, eye examination in coma. There's a test also you must have studied for the person. You have the Glasgow coma scale, right? So yes, so what is the overdose triad? Coma, pinpoint pupils, respiratory depression. So how are you going to treat it? You're going to give the antagonists. What are the antagonists? Naloxone and naltrexone. So let's see. Yes, correct. Naloxone or naltrexone. So do not forget these two drugs. So now you know how to use naloxone and naltrexone. Yes, whenever a person comes in ER with overdose triad, coma, pinpoint pupils, and respiratory depression, or even constipation, sedation, stupor, vomiting, respiratory depression, all of that. So person has overdose. So you're going to give opioid antagonists, naloxone and naltrexone. Easy. So we are done with the antagonists. Do not forget them. Now talking about okay, I was talking about mixed agonist and antagonist. So mixed agonist, what happens is that, let me open this right here. We already spoke about the receptors, right? Okay, let's just come here. Natural versus external activation. Now, okay, opioid receptors belong to a family called G protein coupled receptors. When activated, they reduce pain signal transmission in nervous system. They inhibit neurotransmitter release. They can produce feelings of pleasure, calm. The natural versus external activation. Natural ligands, endorphins, and enkephalins are own bodies. Our body's very own painkillers are endorphins and enkephalins. You must have heard of them, right? So these are natural ligands. They come and bind to the opioid receptors. For the external opioids, you have prescription drugs and illicit substances. Illicit substances like heroin and all of that. Prescription drugs could include any of these mentioned here, right? So these are external opioids. Natural ligands are enkephalins and endorphins that our own bodies produce, right? And these are our body's own painkillers. Why they matter: essential for pain management in medicine, central for understanding opioid addiction and overdose. Overactivation, especially mu receptors, can cause fatal respiratory depression. Now, opioids classification. You can classify them on the basis of their origin. So they have natural opiates. Do not get confused between opioids and opiates. Opiates are basically natural. They're derived from opium poppy. So if you can remember, the very tiny uh, dots in Urdu, we call them khashkhas. So yeah, opium poppy, and it's not even allowed to carry them in airports or anywhere. Anyways, so because they are used to make drugs like heroin and all of that. Examples are morphine and codeine. So morphine and codeine, these are natural opiates. In semi-synthetic opioids, so chemically modified natural opiates, heroin, oxycodone, and hydromorphone. Plant plus lab modification. Synthetic, fully made in lab, fentanyl, methadone, and tramadol. Anyways, you don't need to remember the names, just know the different classifications, right? Now, if you classify them on the basis of the action on the receptors, so some are full agonists, they fully activate opioid receptors, especially the mu receptor. And you have morphine, fentanyl, as I've already told you about methadone and meperidine. Then you have partial agonists, activate receptors but produce less effects, that's safer. You have buprenorphine. Uh, Also, buprenorphine comes under the mixed agonist and antagonist. So just forget about partial. Just use mixed agonist and antagonist. You have nalbuphine. You also have buprenorphine. You also have pentazocine. So this is what I was talking about. Pentazocine. Let's just write this here. Pentazocine. Right. Now here, there's less abuse potential, but can cause dysphoria. Because this could still lead to dysphoria, because what about mixed agonists and antagonists? These stimulate one receptor, which is that kappa, and they block another. So obviously, if they're blocking mu, so there'll be no euphoria, instead there'll be dysphoria. So therefore, there's low chances of abuse here because there's no euphoria. A person wouldn't want dysphoria, right? Antagonists block opioid receptors and reverse its effects. So if there's something already attached to opioid, it's going to reverse that. So example, naloxone and naltrexone. Naloxone, emergency overdose. Naltrexone for addiction therapy. So if a patient comes in ER, so give them naloxone, that's better. No analgesia, just blocking action is done by naloxone. So pain relief, mainly via mu receptors. Euphoria and addiction, again mu receptors. Respiratory depression, mu receptors. Spinal analgesia plus dysphoria, kappa receptors. Easy, full or fully dangerous, partial, protective sealing, mixed, confusing effects, and antagonist anti-opioid. Then moving forward, opioid versus opiate. So opiate is just a natural substance. Otherwise, you have opioid receptors, and receptors have their proper names, mu, kappa, and delta. What's the point of opioid antagonists? So antagonists basically they're actually clinically crucial because they reverse or prevent dangerous and unwanted opioid effects. They bind to opioid receptors, especially mu, but don't activate them. They block opioids from working. So they bind to especially mu receptor, right? So they stop them from working, especially naloxone and naltrexone. So in ER, you give naloxone. So in opioid overdose, respiratory depression is the main cause of death. So what's the emergency overdose type? So there would be pinpoint pupils, there would be coma, and there would be respiratory depression, right? These were the three things in the, yeah, these three things. So it's treated with naloxone. Acts within minutes, restores breathing, used in emergencies. And if you want to treat a person's addiction, so if you're treating opioid dependence, then you'll use naltrexone, relapse prevention. It blocks the high if opioids are taken, reduces motivation to relapse. Uh, okay, that's pretty much it. Moving forward, who takes opioid antagonist in simple terms? So who takes the antagonist? When you talk about antagonist, I've already told you naloxone and naltrexone. So people who overdose on opioids like heroin, morphine, fentanyl, they are given naloxone. So if a person is dying from opioids, you've seen the triad, you have to give them the antagonist to save them, particularly naloxone. People recovering from opioid addiction, they take naltrexone, right? So that's pretty much it. Let's move forward. So here we've done about these are agonists, opioid agonists. These are the pharmacological effects. Then you have mixed. These are the effects: sedation, dizziness, basically clinical use is for pain management. Then you have your also opioid dependence, the treat. Then you have your opioid antagonists. These are basically used to treat opioid overdose, alcohol dependence, and it prevents opioid induced constipation. That's pretty much it.